Welcome back. Our last topic for this week is health. Health inequity is the difference in the access and standard of care one is given, depending in large part on your identities, particularly socioeconomic status. The more dominant identities one has, the more likely one is to receive high quality health care, and the more likely one is to have good health insurance to cover that care. The more marginalized identities one has, the more likely one is to receive lower quality care, and the more likely one will need to pay for that care out of pocket. There are a number of areas that show the patterns of health inequity. The first of these is access to nutritional food and education on nutritious eating. There's a strong correlation to what we know as food deserts, areas without grocery stores or other ways of accessing fresh foods, and higher levels of nutrition-related diseases such as malnourishment, diabetes, and heart disease. Second of these is maternal mortality rates. How often someone dies from complications due to pregnancy and childbirth. This is a widely used statistic that correlates strongly with the overall strength of a region's healthcare system. The United States maternal mortality rate has been steadily increasing over the last 4 decades. What's most disturbing is the maternal mortality rate for Black Americans, almost 2.5 times higher than that of white Americans. Serena Williams, the tennis player's pregnancy experience, is a case study in how racial bias can affect medical care, regardless of socioeconomic status. Williams has a known history of pulmonary embolisms, small blood clots that can develop in her lungs and can be life-threatening. Shortly after giving birth via C-section to her daughter, she began to experience significant breathing problems and informed the nurse that she needed a CT scan and blood thinners. The nurse thought the pain medication was making her confused, but brought in a doctor after Williams insisted. The doctor proceeded to perform an ultrasound on her legs, which found nothing. Finally, after significant delay, they sent her for a CT scan and discovered she did indeed have blood clots in her lungs, and started her on blood thinners immediately. However, the delay took its toll, and the frequent coughing Williams experienced because of the blood clots ended up rupturing her incision and forcing an emergency surgery. Williams ended up in the hospital for another week and was confined to her bed for 6 weeks once she was able to return home. Because her concerns were not thought valid by the medical staff, the delays almost cost Serena Williams her life. Finally, we're beginning to understand the impact of environmental health. People living in urban environments have shorter lifespans, and that correlates to neighborhood. The poorer the neighborhood, the shorter the lifespan. This is due in part to the general environmental pollution of cities, but it's exacerbated by poorer neighborhoods. Housing in poorer neighborhoods is less well maintained and more likely to have issues of mold, asbestos, and lead paint. Poorer neighborhoods are often, or have been in the past, sites for industrial manufacturing that leach chemicals into the air, ground, and water. Even if those factories are long gone, their environmental legacy can linger for centuries and is very expensive to clean up. Poorer neighborhoods also have less green space, which reduces trapped heat and helps cleanse the air. Let's examine how different identities affect healthcare. Socioeconomic status is probably the biggest factor in health inequality. Your level of income and type of job strongly impact the availability, quality, and cost of health insurance. Lower paid workers, particularly hourly workers, may not have employer-offered health care, and if they do, it is often minimally subsidized and therefore considerably more expensive. Poorer people are more likely to access their health care through clinics, which stay profitable by volume of patients and tend to provide less personalized and thorough care. Wealthier people are more likely to see medical professionals in private practice, where the insurance costs are higher, where the individual costs are higher, and are usually absorbed by health insurance, and the care is more individualized. Racial bias is well documented in the medical field. Doctors, like all people, are subject to stereotypes and biases, and have a lot of latitude in treating patients. A study published in 2016 found that almost half of all white medical students surveyed believed that Black people physically feel less pain, and their suggested treatment plans bore out that belief, offering less powerful pain medications to their hypothetical patients. We see this pattern show up in actual clinic settings as well, where Black patients are routinely denied pain medicine or given less powerful pain medicine. Black and Latinx people are often over-scrutinized when they request medication as well, another study found, with many medical professionals believing they were more likely to sell their medication than use them. Finally, the overall stress of racism appears to lead to increased health problems as well. Black and Latinx Americans have higher levels of stress-related issues that do not appear to relate to diet, behavior, or socioeconomic status. Gender bias in the medical profession is an issue as well. Women's health complaints are often taken less seriously, and thus serious issues are not found as quickly. Many studies and treatment plans have been based on male subjects, and we're beginning to understand that the same physical problems may present differently in men than in women, and thus go undiagnosed in women. Many drugs have been tested primarily on men, with side effects and dosing based on those studies, which may not have the same effect in female bodies. Finally, women need access to reproductive health care, which is often not covered extensively by insurance, and which has been politicized and access limited in many places. LGBTQ+ people face many biases in the medical community as well. These range from intake forms and questionnaires designed only with cisgender and heterosexual patients in mind, to individual medical professionals' personal biases and unwillingness to treat LGBTQ+ patients. Transgender patients in particular have a difficult time finding medical professionals willing to treat them, and have experienced such discrimination from emergency medical technicians that some have actually died because they were not given the care that needed. Research on gay and transgender issues often does not exist, and many medical professionals receive little to no training on LGBTQ+ care without actively seeking it out. Let's take a few minutes now to discuss the association of race and disability. Historically, enslaved people were seen as physically superior, but intellectually inferior, and the exploitation of their bodies by the people who owned them created physical disabilities. The systemic inequalities and outright violence faced by Black Americans throughout the centuries has created a higher percentage of Black Americans with disabilities relative to population. This history of physical disability and supposed intellectual inferiority has limited Black Americans and created a negative association between Black and disability. Thus, critical race scholars have sought to disassociate Blackness from disability. However, critical disability scholars would say that disability is also a social identity created by a history of exclusion, that merely having the identity creates barriers rather than someone's actual physical or intellectual abilities. Therefore, it is essential to align both groups through their history of exclusion, and in particular to recognize the intersection of race and disability. Less ableism means less racism, and less racism means less ableism, because they're used against each other to create more barriers. Let's look at those intersections for a minute. Black children are more likely to be labeled as having intellectual disabilities than white children, and particularly in urban environments, are more likely to be placed in special education, especially those for whom English is not their first language. This reduces the access to opportunities over the course of their educational career, making it more difficult to have all the skills necessary for employment. We can see that reflected in the unemployment rates for Black Americans with disabilities. They are more than twice as likely to be unemployed a few years out of high school than their white counterparts. Finally, Black Americans with disabilities are far more likely to be arrested than white people with disabilities. We'll explore that a bit more next week. I'd like to take a moment to introduce you to the concept of epigenetics. This is the study of how gene expression, which genes are turned on versus off, change over time. The field is fairly new, and one of the areas being explored is how trauma affects transgenerational gene expression. Literally, can we see the effects of our ancestors' traumatic experiences in which active genes we carry? Some of the earliest research was looking at the genes of Holocaust survivors and their offspring. There were some links, but the results are considered controversial. Further research has examined descendants of enslaved Black Americans, Native Americans, and refugees, with some promising results that suggest changes in gene expressions that promoted survival, but also have long-term health consequences, and those changes have been passed down. While I think this research is interesting and promising, I need to leave you with a couple caveats. First, it's difficult to unlink transgenerational trauma that appears through passed down social behaviors and ones we may see in gene expression. Second, because this is such a new field, not a lot is known about it, and there are people who will claim anything from a particular diet to meditation will improve the genes of your future children. These are unfounded claims, and if you decide to look into this further, be wary of them. Before we wrap up, let's take some time to examine how health inequities have shown up during the COVID-19 pandemic. In many places, certain jobs have been designated essential, jobs that are necessary even while the rest of the population has experienced stay-at-home orders. While some of these are doctors and nurses, many more have been low-wage type jobs like cashiers, janitors, inventory stockers, home health aides, and delivery people. These people are more likely to be poorer and to be non-white, and their essential status means they are far more likely to be exposed to infected people, without the training and equipment medical professionals have. Furthermore, those low-income workers usually do not have paid leave, and therefore often end up working while sick. A problem during any time, but particularly bad during a pandemic. For low-wage workers who have not been deemed essential, much of their work cannot be done remotely, meaning more often than not the shutdowns have caused them to be unemployed. These types of positions rarely include healthcare, extra important during a pandemic, but those who have lost their employment have likely lost their health insurance they had through their employer. Location creates issues as well. Poor urban environments tend to be more crowded and less well maintained, and have more people working in high contact essential jobs. This means transmission rates for those neighborhoods have been higher than they would be in less populated areas. Rural areas, by contrast, may have lowered transmission rates, but healthcare is not as easily accessible when there are issues. Finally, the personal biases we've discussed earlier work against marginalized people, meaning their complaints are taken less seriously and their treatment delayed until it becomes more serious and more difficult to treat. So how does this show up in data? We can see how wealthier workers are dramatically more likely to be able to work from home, and how very few of the poorest workers have that ability. We can also see that the majority of pandemic-related layoffs have been in the service and retail areas, areas with slim margins and low rates of pay. We can see this in rate of infection and rate of death. On the left is the racial breakdown of the state of Michigan, which I've used because they've had some of the most accessible data. All things being equal, we would expect the breakdown of cases to be at least similar to the racial breakdown of the population. However, what we see is a huge number of infected Black Michiganders relative to their population, while white Michiganders have significantly fewer infections based on population. Some of you with sharp eyes might have noticed the unknown category in the cases by race. But even if 100% of those were white, there would still be skewed results based on race. Illinois' population is similar to Michigan's, but again, we see similar results. Black Illinoisans are significantly more likely to contract COVID-19 by percentage of population, and have more deaths by population as well.